started. We are discussing pain with sex and how OB-GYN and pelvic PT work together. So I'm really excited. And we have a new format that we're going to be trying out today, so I'd love your feedback on it as well. I've turned off commenting because we're going to post this on YouTube, and so we're going to be side by side so we don't have text on our faces. So we'll be getting connected here. I hope you guys are having a great day. Again, we are discussing pain with sex and how pelvic therapy and OB-GYN work together. So, we are just getting everything set. Thank you guys for sticking in there. Let's see. I think that we're getting there. I still see little hearts, so that's sweet that you're just waiting for us. Let's see. Oh, she's trying to join. Let's see. Let's try something else here. Okay, I'm going to send you a link. I just added you. So look in the little, should be a little circle. Hey,
there we go. Great.
Excellent.
All right. Now we're all
Yay.
set. I just need to be invited.
Yes. Well, so I'm glad we connected. And how's your day going?
It's great. Thanks so much. How's yours?
Good. Yeah, it's good too. I've been looking forward to this. For everybody out there, we tried this back in June, and technology issues on my end prevented that from happening. So I'm glad that you carved out some time for us and that we got connected again.
This is great.
Super excited.
Well, this
go ahead.
Is a topic I'm so passionate about. I feel like so many women have pain with sex and they think it's normal, and it is not normal to have pain with sex. And there are such great treatments that when I have women who have pain with sex, almost all of the time we get them back to a really healthy, enjoyable sex life. Yeah,
there's so much that can be done and people just aren't aware of it. So it's a really, really exciting and very rewarding area of therapy and interventions. So let's get started with, would you tell us a little bit about yourself and your background and where you're located?
Yes, so I am Dr. Marta Perez. I am a general OB-GYN doctor in Jacksonville, Florida. I work in private practice. I see all women of all ages, from teenagers through postmenopausal women. I help women find a birth control that works for them. I help them throughout their pregnancy, prenatal visits. I do deliveries. I help them afterwards. We manage painful periods, do hysterectomy, surgery, all of it.
Nice. Okay, good. So you have just a breadth of experience there, and that's amazing that you're helping so many women across the lifespan.
It's really fun.
Yeah. Okay, so we're going to jump into some of our questions here. I'll just start with number one. So do you routinely screen for sex with your patient, for pain with sex with your patients? And then if you do, what does that look like in your office?
Yeah, so I typically screen for pain with sex both on some intake forms as well as when we sit down. So part of our intake forms for a preventative health visit will ask, about pain with sex. But some people gloss over that, or they may not want to write it down. Mm-hmm. So during my preventative health visit is when I think it's a great time to ask, how is sex going for you? How is your intimate life? Are there any issues you want to discuss? I would say that if your doctor hadn't asked before, it's not always the top of a woman's complaint list too. If you're coming in for a visit about really painful periods or needing to switch birth controls, well, we might not address sex in that visit. But as a wellness visit, I really do try to touch on how is your intimate life, how's your sexuality, are there anything you need to discuss in that way?
That's amazing, because I think number one, so many people don't even know that there are interventions for it,
Exactly.
right? And then number two, even if they knew, they might be kind of shy to bring it up. And it's somewhat intimidating too, being in the doctor's office. And if you're not a confident person and you're not even sure if there is help, you're probably not going to bring it up. So the fact that you're initiating the conversation is huge.
And the other issue too is that women's sexuality in our society is often very much ignored. So a lot of women who feel really uncomfortable and have pain during sex, they've been socialized to believe, well, women aren't supposed to enjoy sex. So it's okay that I don't enjoy it. And that is definitely not the case.
Just grin and bear it.
I know.
No!
I know. No way.
No, exactly. It doesn't have to happen. So I'm so happy that you're doing it from a prevention standpoint, but also being proactive with the people that you're interacting with. All right. So for someone with painful initial penetration, what are diagnoses you would rule out prior to referring to therapy?
Yeah. So, when I'm evaluating pain with sex, there's tons of different causes, and it really takes talking to a woman to figure out what kinds of pain. You mentioned initial penetration. There's also deep penetrating, or there's other types as well. So talking and getting a history about what it is that's painful and what it feels like. And then doing a physical exam. So certainly pain with initial penetration often will have to do with the physical anatomy towards the outside. So either the vulva itself being painful, irritated, having a physical condition, or the introitus of the vagina, as opposed to focusing on the uterus or internal pelvic muscles as much. So I do an exam focused on the outside, but I also do an internal exam. Specifically, a lot of skin conditions of the vulva can cause initial penetrative pain. There can be inflammatory and autoimmune conditions, but also something really simple, which is vaginal dryness. That's a common problem for peri and postmenopausal women. Actually, also a really common problem in breastfeeding women as well.
Because of that estrogen.
Exactly. Breastfeeding has your hormones levels really low, and it can almost mimic a perimenopausal or postmenopausal state. And a lot of young women don't know that, to expect that with breastfeeding.
So I'm going to go off topic just a little bit. So if it was vaginal dryness during breastfeeding, what are some things that you would suggest?
Yeah, so certainly lubrication is great, but lubrication itself during the sexual act may not fully resolve it, or may not work for the woman. She may be interested in vaginal estrogen therapy, which is definitely something we can do. And that does not affect breastfeeding, even if you have a male baby. That's a common misconception. So that's something that's, really successful at getting women more comfortable.
Good. And so that's a cream that you apply externally.
Correct. Yeah. And then, of course, another big aspect of dryness is, physical dryness, we need to use medications for. But another thing with some is longer foreplay. Women's bodies will lubricate more when they have longer foreplay. So you have to kind of, again, talk to them about what's going on, physical exam, but these are all kind of parts of all things that women can try.
Right. And it's not just a penis, or it's something being inserted into the vagina. Right. There's so much more to sex. And just as a disclaimer here for everybody joining us, when we're saying sex here, we're talking about vaginal penetration, basically. Yeah. Okay. So then going to the deep penetration. So what are some things that you would kind of be on the lookout for deep penetrative pain before sending them to therapy?
So deep penetrative pain is often blamed on the cervix and uterus, which it can be, and I'll talk about in a second. But as you know, and as more OB-GYN doctors are knowing more and more, though not all are aware of, the pelvic floor muscle has a lot to do with that. And a lot of women only think pelvic floor and Kegels. And I always tell women, I would love to hear what your analogy is. Yeah. My analogy is if your muscle is strained and super tense, like imagine your bicep being super strained and super tense. You don't go to the gym and work it out even more. That's going to cause it to be more in pain. You need to understand how to let muscles relax. So
beautiful.
Evaluating the pelvic floor muscles is going to be really important. It's not just Kegels as the option. You need advanced therapy with someone like you. But also evaluating the uterus. Sometimes deep penetrative pain occasionally can be a certain time in the cycle or a certain position. Okay, that can be normal for women. Sometimes, I always say, it's abnormal for sex to hurt all the time, but it's okay for certain times of the month or certain positions, just not to quite work for your body and change, and then it should feel better.
Yeah.
But certainly conditions like endometriosis or fibroids on the uterus, ovarian cysts, they can all make the uterus feel uncomfortable and crampy. Even some women who have their uterus tilted back occasionally report more discomfort with deep penetrative intercourse. That's not a condition or something wrong. It just takes a little bit more troubleshooting in terms of which positions work for them.
Mm-hmm. Good. And so just the takeaway there is persistent pain is not normal. So
yes.
If you have a little bit of pain with a certain position or a certain time of the month, it's not something to get super worked up about.
Exactly.
You can change it and you can modify it and you have the power to control it.
And if you're not sure if it's normal, ask a provider,
Yeah.
I think that, I have women who, I put up my post and they say, well, sometimes, I said, pain with sex isn't normal. And they said, well, what if it's just sometimes and we change positions and it's better? And that's fine.
Right.
Right.
But understanding your body.
There's more women who suffer and don't enjoy sex and always have pain, and we need to reach those women and let them know there's help out there. We can fix this.
Yeah. And I would even go so far, if there's a specific position that you really like and it used to be pain-free or you want it to be pain-free, there may be some strategies that we can use to help you achieve that goal. So,
absolutely.
Okay, good. So the next one, do you find that most people with painful speculum insertion also have painful vaginal penetration with sex?
That's such a great question. I would kind of phrase it this way. Many women who have pain with speculum insertion don't have pain with sex. The environment of being in a strange doctor's office, completely naked,
cold,
hearing some metal or plastic device with a stranger in that strange position in the stirrups, that is an alienating and uncomfortable just situation. So having discomfort during that, not surprising. Mm-hmm. However, the opposite I feel like is true. A lot of women who have a lot of pain with sex do have some discomfort, probably more discomfort with the speculum exam, although not all. So, I definitely am from the get-go more slow and intentional and talk women through if the complaint is pain with sex as we do the speculum exam. I want them to know exactly what's going to happen and how, and to tell me when pain happens, because it can help with the diagnosis.
That's beautiful. I love that you're talking about it. Yes.
Yeah. It really helps. Mm-hmm. I always tell women if speculum exams are very uncomfortable for you or they create a lot of anxiety, let a provider know, because it's different in how we approach it.
Mm-hmm. Good. All right. So everybody out there that you heard that, let the provider know. Talk about it. Mm-hmm.
Exactly.
Okay. So then once you refer to pelvic therapy, mm-hmm. what are your clinical expectations and then also your ideal scenario for communication back and forth from the therapist?
So often, this is super individualized because there's just so many things that can cause pain with sex. But sometimes we're taking one kind of more medical approach and with physical therapy. So a lot of times there may be a few treatments we're trying at the same time. Someone's doing physical therapy at the same time they started birth control pills to control endometriosis, or we start evaluating an ovarian cyst or something like that. Or we start with vaginal estrogen for dryness and do physical therapy. So I always tell women this may be a multimodal approach. And what I want us to do is come back after the course of physical therapy, assess how much improvement there's been and what still needs to be improved upon. So I always have a follow-up available. I say put something on the books for, 8 weeks, 12 weeks, or whenever your pelvic therapist says to come back, and we can kind of circle back and see where are we now and where do we need to go from here.
Mm-hmm. Good. That's great.
But I'll tell you what, most people after their physical therapy, they say, I'm great now. This is wonderful. So it just goes to show how valuable that is in our therapy.
Yes. I remember when I first started, so this was back in early 2000, going to offices and just kind of getting laughed out of the waiting room. Like, it's not a real thing. And so we've come so far in 20 years.
And I think that some doctors may not still be super aware of it if they don't live in an area where there are a lot of pelvic therapists, or if they haven't had a lot of exposure to how, there is great research supporting how therapy should be out there. But sometimes some people may not be aware of that. So
Good. I love it. Okay. So anything else you want to share in terms of your piece of the pelvic pain and pain with sex?
I think the biggest thing is telling your provider. And if you don't get a supportive response from a provider, to think about telling another provider, because this is something that's really important for women. It's important to have a healthy sex life and enjoy sex, and there are solutions. So if you don't feel heard by the person that you tell as a healthcare provider, find someone else who's going to help you find a good answer for it.
Yeah, good. Excellent.
And then I wanted to start asking you some questions.
Yes, I'd be happy to.
So when you get a referral for pain with sex, what do you find on your assessment is sort of the most common cause?
So the most common cause would be overactive pelvic floor muscles. So I have some images here that I'm going to see if I can pull up.
Oh, great.
It's kind of sideways.
Yeah.
So we have the pubic bone and the tailbone, and then you have the pelvic floor muscles that stretch from the front to the back, and then here's the bottom view.
Yep.
So
I always say they act like a basket supporting all the organs.
Exactly. This view is like if you were looking into the pelvis from below, like from the knees up, right?
Right.
And so all those red areas are muscles. And so you have 17 pelvic floor muscles that are holding your organs up, and they also wrap around the canals. Yep. All right. So with overactive pelvic floor muscles, I very much like the analogy that you used with the bicep. I also love the hand. So if you think about a hand and it's squeezed all the time, how well is that hand going to function when you release? It's not going to work well. And if you try to insert, so let's pretend like this is the vaginal canal, and these are the muscles, and the muscles are tight. When you try to insert something in there, it's going to be painful. So I would say overactive pelvic floor muscles are the most common cause of pelvic floor, of pain with sex that I say.
Pain with sex, especially the ones that get referred to you, because something like dryness may not initially have a referral, or only if it's kind of still painful after the dryness part is addressed.
Exactly.
Another question I had is, what are some new or emerging or exciting kind of therapies that you've seen?
Yes. Well, I'm excited about everything with pelvic therapy. So some of them may not necessarily be new, but they're being refined over time.
Exactly.
So I have a lot of little demos that I brought here.
Oh my gosh, love it. I love it.
Number one, this is very simple, but it's called perineal massage, and it's actually something that people can do at home. So I have my pelvic model.
Love your pelvic model.
That's the vaginal entrance, and then that's the anus. Okay, so this is the perineum. I have a couple statistics here that I'd like to share as well. So about 60% of women at 3 months postpartum are still having pain with sex. That's a lot. 60%.
That's a lot.
Think about how many babies are born. Okay.
And the other part that's challenging is that, in our current postpartum care model, we see women at 6 weeks when they haven't initiated sex yet.
Yeah.
And so, I started telling women after the end of that 6 week visit, even though this 6 week visit is kind of the end of your postpartum journey in this office, you need to let us know what postpartum issues come up. Please come back and see me if you're having issues, you have discomfort with sex, or I kind of go into other breastfeeding problems, et cetera, but it's really important to note that some women say like, oh, I'm done with the OB-GYN now because we had our 6-partum visit, and I don't want my patients to feel that way.
Right. That's good. Because also a research study was showing that 76% of women that have leakage at 3 months still have it 12 years later. So that's something else that you can, that you
like that
talk about.
That's good to know.
Okay, so going back here, so this is the area that is torn typically if you tear, this area between the vaginal opening and the anus. And so scar massage, and then you see that these are muscles there too underneath that skin and that fascia. So perineal massage is huge. Some other things that I love are biofeedback. Okay, so biofeedback is a really, really helpful tool to retrain your muscles to do the right thing at the right time, especially for overactive pelvic floor muscles. Now, it's a tool, okay? So it's not, you need to have skill with using it. And you need to, have the right environment and instructions and so forth.
Yes.
So there are different types of biofeedback. The type that we use the most is called surface EMG, and it's very similar to an EKG of the heart, where we hook up the muscles
looking at the muscle
with electrodes, and we're looking at the electrical activity of the muscles, okay? So going back to our pelvis here, we have multiple types of electrodes that we can use. So if you're having pain with penetration, we may not want to use an internal electrode initially, right? Because if you're having pain with anything going inside, why do we want to put something inside right now? But if you look at this little sensor, it has these little silver strips, and that's what's reading the electrical activity of the muscle. And we have different sizes, and then the cord gets hooked up to the computer. Okay. But we also have some external type electrodes. So we put those on the outside
on the
of
muscles.
the perineum. And so that's a nice tool. All right. We also have something called Dilator Stretching. Okay. There's a lot of kind of self-help programs out there about dilator stretching. I really encourage you to have a relationship with a healthcare provider. There's a huge nervous system component to pain with sex. Okay.
Exactly.
So yes, the muscles may be tight, but just saying muscles relax, that's probably not going to happen. We've got to teach them. So one way we can teach them is with biofeedback. Another is with the perineal massage. But you may just, if you have a lot of anxiety and you're really, really tense, you may just even start with putting a finger right here, not doing anything, and focusing on some deep breathing. You know, diaphragmatic breathing, and trying to just kind of relax your system. Okay, so nervous system quieting. Then, so let's go into dilators. Okay, so there's a lot of different types of dilators. This is great. I like the flexibility and the pliability of this type. This is from Intimate Rose. And so starting with a baby dilator, usually you're working on gently inserting this into the vaginal canal. And so sometimes I'll have people just gently rest it there right at the entrance. Okay, we don't need to jam it in. We're not, that's defeating the whole purpose. You've already had things jammed in, right?
That wasn't working.
Exactly. So we're trying to just gently stretch. And then let's pretend like this is that perineum. So I like to just give some sustained deep pressure, and then kind of you can do some sweeping motions. Or if your vaginal canal is surrounding this and it's tight, you may just have static stretching. So you have static stretching, dynamic stretching, deep pressure, light pressure. And with all of this, we're wanting to breathe and be in a comfortable position.
Be in a calm state. Help keep the nervous system in a parasympathetic.
Yes, exactly. Lock the door. This is the time. I love to do this in the bathtub because you're reclined. You have some nice warm water. Don't forget lubricant. So I think coconut oil is one of my favorites, but we want some lubricant. We're not trying to insert this into a dry vaginal canal. And also the bathtub has leg support on either side. Because if you think about trying to do this with your legs being held up and your adductor muscles are firing to keep those legs in the right position.
Right? That's interesting.
And that connects right into the pelvic floor. So we want to be as relaxed as possible. I've even had people say they've tried this in standing. Well, standing, your pelvic floor is engaged. It's part of the core. It's needing to work. So we want to just try to be in as relaxed of a position as possible. And then starting with a small dilator usually, and then we have all kinds of sizes. This is the next. This is an 8-set series. So then this is the next size. I'll skip a couple. Here we go to the next size. Second to the biggest, and then we have the biggest. Okay, so you don't have to use all sizes. It kind of depends on what your goal is, too.
What's the goal?
Exactly. All right, and then this is a book that is really helpful. It's written by a therapist.
Okay.
I think it's reversed, right? But
Yeah.
it's called Sex Without Pain.
Wow. How
And
great.
so she's on Instagram. She's the Lady Parts PT. And so she kind of walks you through a whole dilator stretching program. And I think that's a really helpful tool because there's going to be people that don't have access to pelvic therapy for whatever reason. Maybe it's finances. Maybe there's no one in their area.
It could be
maybe
distance,
it's social too. Like, hey, I'm not going to do that.
Yeah.
You know, and there's people like that, and that's okay.
Or childcare too, you know.
Yes, there's so many factors. So basically that's a nice strategy. And then there are also more therapists that are doing online consult sessions too, which can give some intervention. Yeah. I don't think any of that replaces the one-on-one and the hands-on, but it's a plan B if plan A isn't possible for you.
Mm-hmm. Yeah. Yep. And that's all about like increasing access too. If we can't have like in-person access, which is going to be the best, then at least having some access can help women a ton.
Yes. And with my PFM, that's really our goal is to be able to give like free educational resources in many languages to connect with people all over the world. Because I think that even in the U.S., our access to pelvic therapy is limited, right? But think about other countries.
Even our access to healthcare providers is so limited as well. Yeah. And there's so much that women don't understand about their bodies and how they can, what a problem could be and that it can be addressed. So even getting someone in the door, like I saw this on my PFM, that this is something that can happen to women. Yeah. And I found out that people can fix it.
Yeah, so just raising that topic,
I was going to mention to my doctor, but now I realize that I need to tell a healthcare provider about this. That we can, because I found some answer when I stumbled across it.
Yes, exactly. So those are some of the key things. There's also something called a wand that is kind of like an S shape, but I would not suggest that you do that without the skill of a therapist. But with the wand, let me just kind of go over a little bit of the anatomy here. So you have several layers of pelvic floor muscles. You have the superficial layer, a deep layer, and then you actually even have this muscle in here called the obturator internus.
That's such a
tough
key layer.
muscle to access.
Your low back, and so your hip, I mean, all of that, the obturator OI, obturator internus, has so much to do with, I find a lot of women who are in great shape and very athletic have a lot of obturator internus stress.
So think about so with this straight dilator, and we're inserting that, how is that going to get around that like little ledge to get into the obturator internus? It's really not. So the wand is a nice kind of S shape where you can insert it, and it can kind of hook over that ledge. But again, I would not suggest people just get the wand and start playing around. Do that with some direction. Do that with some direction.
Yeah. Well, that's so great. I tell women all the time too, when I'm doing the exam of the pelvic floor muscles, that, I kind of touch their thigh as a sample, like this is a muscle, the quadriceps muscle. I'm pushing on it here, and it's pressure but not pain. So I'm going to be feeling muscles on the inside as well, and let me know what you feel.
So I'm going off topic again, but I love that you're such a huge advocate for pelvic health. Did you learn that in medical school? Did you have a mentor? Like, where did that come from? And I love it.
Yeah, so not so much in medical school, but definitely in my OB-GYN training. So I'm a general OB-GYN, but during residency for OB-GYN, you have to work closely with not only just general OB-GYNs, but you work closely with, high-risk OB specialists, gynecologic cancer specialists. But one of the specialties of OB-GYN is female pelvic medicine and reconstructive surgery, which is also called urogynecology, which providers can become urogynecologists either through doing an OB-GYN path and specializing, or through a urology path and specializing as well. And those types of special doctors treat a lot of pelvic pain conditions and a lot of prolapse conditions, interstitial cystitis, things that involve the way the pelvic floor all works together, which are sometimes surgical interventions, but they're often non-surgical. And they are the ones I worked with at WashU are, I think, some of the leaders in the field in terms of including physical therapy as an integrative part of that practice. Though I think that in that field in general, physical therapy is heavily stressed. So that's where I kind of learned it. And a lot of times I'm the first access point. People don't know to look up a female pelvic medicine reconstructive surgeon to access in their area. But they will come to their OB-GYN. So I think being the first line and knowing, this is what I think is going on, and this is a treatment. And then certainly if we're not able, if it's something's very complex or we're not able to get satisfactory treatment, I refer on to those specialists. But being able to adequately assess and treat, I think every general pelvic pain and pain with sex every OB-GYN should have that. And so I'm really grateful for that training that I got about the power of physical therapy.
Yeah.
I got to go to a pelvic physical therapist office for one afternoon and see a lot of it was only 2 patients that day, but see the assessment and some of the treatments. And honestly, Jeanice, I wish I could even do that even more, because I think you guys do really fantastic work.
Thank you. Thank you. Well, it's such a rewarding area of therapy, and just so amazing to have that impact on quality of life.
Absolutely. Mm-hmm. Yeah.
Good. Yeah. Well, any other questions for me?
Let me go over. I was going to ask, besides OB-GYN doctors, what other doctors do you get referrals from, and what do you wish that more doctors knew about pelvic floor therapy?
So, we have a pretty good relationship with the physicians in our community after 20 years of talking about it, right? Yep. So we do see referrals from family practice, sometimes from, and this is pain with sex. We definitely see referrals from other providers for other types of things. But some of the family practice doctors are referring for that. And then also urology, colorectal. But it's primarily OB-GYN, the team there. And then I really wish that all healthcare providers knew to screen, and not just to have it on the form, but to directly ask like you're doing. So having that relationship and bringing it up. Don't rely on the patient to bring it up, because again,
it's hard to bring up.
They may not know, they may not have the confidence, they may be intimidated, they may just, have this other list of priorities. But pain with sex can even point in other directions, that there might be some other dysfunction happening.
Absolutely.
And so asking, and then once you ask and identify, knowing that there are other resources out there. You don't have to know everything. We don't know everything. But just knowing that there are resources and connections, and that it's not in their head. Don't just say, it's in your head, go drink a glass of wine and relax.
No, I can't stand that one.
That is offensive. Okay.
It's totally offensive. My heart hurts so much when I have women say that to me, because that's not at all. Yeah. It's not right. It's not the truth either. Sex it's not. Easily accessible.
And we have research. It's not just these pelvic therapists that are singing our own praises, right?
No.
So we have a good body of research, and we have so many great case studies. And
absolutely.
So, there was one other thing I wanted to say, but I forgot it.
It might come to us.
I know. I don't know. It's not coming quickly. So anyways, I think that's just incredible. Oh, I know what it was. The provider. You mentioned that earlier as well. But if your provider isn't listening to you, whether it be your primary provider or even your pelvic therapist, because all pelvic therapists may not connect best with every patient. Sure. So if they're not listening to you and you're not getting the outcomes that you want, I would switch providers. Yep.
And as a healthcare provider myself, I always tell people, if this would be my treatment plan, if it doesn't seem to fit what your expectations are, or you doubt that maybe you don't agree, I'm happy for you to get a second opinion with another provider, because
I agree.
Everyone has a different skill set, but different people approach things different ways.
They do.
We all need to support a patient's value system and journey. And if you don't feel like, if a patient doesn't feel heard, it's my job to make them feel heard. But if they want to look around or want a second option, then that's great. So every competent healthcare provider should be not personally offended, but totally open to second opinions.
Exactly. I'll generally say you should be seeing some improvement within 4 to 6 visits. Okay. Yeah. So if you've been to a therapist for 12 visits or 16 visits and you're not getting better, you absolutely, I like to have the conversation with the provider first, like, hey, I'm not getting better. But if it's been 12 to 16 visits and they haven't asked, I would look for someone else.
Yeah. And maybe a reevaluation too, back to kind of, we ruled out kind of these things. Maybe something else is going on that we need to look more into.
Right. But that's not really the responsibility of the patient. Right. Sure. It really should be the responsibility of the provider to keep checking back. Okay, well, how's this going? Maybe you're not able to have penetrative vaginal sex yet, but you can insert this vaginal dilator halfway for 10 minutes and not have pain. So progress is also viewed differently. And so kind of breaking it down. And as a physical therapist, we do this. So we have short-term goals and long-term goals, and we break down things into specific, achievable time frames. And so I think that's helpful too. But we need to make sure we're incorporating the patient's goals. So just because I think it's a goal, that may not even be a goal for you.
Right. Totally. Absolutely.
Good.
All right.
Well, this was amazing. I know we went a little bit past our 30 minutes, but thank you so much for your time and your expertise and your passion.
I love your models. I love your education.
Thank you.
And I just think this was so fun.
Yes, and we'll do it again. So many
definitely.
topics. Yeah.
Yeah.
All right. Exactly. Well, have a great day. Thank you, everybody, for joining us. Bye-bye.